Dear friends, dear colleagues, we are starting one of the most important sessions dedicated to the new TB drugs regimens within research. Each representer has 15 minutes. We start the session with discussion of one of the most important issues, sputum conversion, reversion among patients of new TB drugs. Dr. Helena Huerta, please.
Good morning. So I'm going to present results on sputum conversion and reversion among patients on new TB drugs. These results are from the NTB observational study. So first of all, I'm going to present what is the NTB study, the NTB project. The NTB stands for Expand New Drugs for Tuberculosis. This is a project that is being conceived and is being implemented by 3 NGOs, Doctors Without Borders, Partners in Health, and IRD, Interactive Research and Development. This is a project is funded by UNITAID and has 4-year duration from 2015 up to 2019. The goal of this project is to expand access for bedaquiline and delamanid, and that's the main goal of the project, and also to provide evidence on these new drugs. And for providing evidence, we are conducting 2 studies, one observational study that I'm going to present now, and one clinical trial that Lorenzo is going to present later. Sorry. Just forget to mention, there is a website. Do you have the address there? It's ntb.org if you want to know more about this project. So this project is being implemented in 17 countries and aims to put on treatment at least 2,600 patients. So you can see in the map the countries that are participating in the project. It goes from South America in Peru to Africa, South Africa, Lesotho, Kenya, Eastern Europe, Central Asia, and Eastern Asia as well. So there is Belarus making part of the project, Kyrgyzstan, Kazakhstan, you will see with the patients. So now let's talk about the study itself. So this is the study that I'm presenting is an observational study. It aims to assess efficacy and safety of bedaquiline and delamanid used in programmatic conditions. So for that, we are following a cohort of patients that have been started on these drugs, and this is a multicentric study. So the population of the study is just patients that have been started on new drugs, bedaquiline or delamanid, and who have signed the informed consent. There is no any exclusion criteria for the patients. We have done some preliminary analysis looking at culture conversion by 6 months, culture reversion by 12 months, adverse events of interest and serious adverse events to see the safety of these drugs, and expanded indications for the drugs. So I'm going to present the results on culture conversion and reversion. Nino is going to present next the safety results, and Eric will present on the expanded indications. So for culture conversion, we report the proportion of patients whose sputum converted from positive to negative during the first 6 months of treatment with bedaquiline or delamanid. So for that, we did the analysis in a cohort that started MDR3 treatment from 1st of April 2015, when the project started, until end of September 2016, to be able to have enough time for the follow-up of the patients. The patients were included in this analysis are those who were positive culture at the start of the drug, and we went up to 90 days before the start of the drug if there was not a culture exactly at the date of start. So conversion is defined as 2 negative cultures with a sample taken at least 15 days apart, and the date of the conversion is the date of the first of these 2 cultures. Oh, sorry. So here's the enrollment per country. There were 356 patients included in this analysis. And you can see that majority of the patients come from this region of the world. You can see Kazakhstan, Georgia, Belarus, Armenia are the countries that are contributing more to this cohort of patients. And here are the patient's characteristics. For median age is 38 years. There are more males than females. And what it's important to look at is the clinical and resistant profile of the patients. So you can see that there is a number of patients with low body mass index. There is 70% of the patients that have bilateral disease. And you can see in the resistance profile that most of the patients had at least fluoroquinolone resistance. 80% of the patients had at least fluoroquinolone resistance, with almost 50% of the patients that were XDR. When we look at comorbidities, there is a considerable proportion of patients that had comorbidities. 10% of the patients were co-infected with HIV. 20% of the patients were co-infected with hepatitis C, and 13% of the patients had also diabetes. Regarding also use of second-line drugs, 80% of the patients had previously used second-line drugs. Here are the results on culture conversion by 6 months. So from the 356 patients, 291 converted by 6 months, which translates in a conversion rate of 82%. And from the ones that did not convert it, these are 65 patients. 17 have died, 16 were lost to follow-up, and 32 were still on treatment. Here you have in the graph time to culture conversion. The median time to culture conversion was 52 days, which is almost 2 months. And in the graph you can see how conversion goes over time. So in the x-axis you have time from 0 to 6 months from treatment start, and the y-axis shows the proportion from 0 to 100. And you can see that by 2 months, more or less 50% of the patients had converted. By 4 months, almost 80% of the patients had converted. We also look at conversion in subgroups. When we compare, for example, HIV-positive patients with HIV-negative patients, we can see that the conversion was lower in HIV patients compared to in HIV-positive patients compared to HIV-negative. 67% versus 84%. And these patients, that HIV-positive patients, most of them were on ART, on antiretroviral drugs. 1/4 were recently diagnosed. You can see that from the 10 out of the 12 who did not convert died, and the CD4 was quite low. When we look at other groups, like hepatitis C positive versus hepatitis C negative, there was no difference in the conversion rate, 78 versus 83. Looking at diabetes versus not having diabetes, there is no difference either. And when we look at XDR patients versus non-XDR patients, other resistance profiles, there was no difference in the conversion rate either. Now let's look at reversion. So we report the proportion of patients whose sputum reverted to positive after having converted to negative during the first 12 months of treatment with bedaquiline and delamine, or delamine. So this cohort of patients goes from 1st of April 2015 up to end of February 2016, again to have enough time for follow-up for these patients. So reversion is defined as 2 consecutive positive cultures after culture conversion. The countries that are included in this analysis are Armenia, Belarus, Georgia, Kazakhstan, and Lesotho. So there were 98 patients included in this analysis. Patients' characteristics are similar to the group I presented previously regarding culture conversion, with high resistant patterns, more 80% again with resistance at least to fluoroquinolones. And we look at how many cultures these patients had during the follow-up to ensure that the reversion analysis was going to be reliable, and these patients were well followed up with a median of 10 cultures per patient. So 3 patients reverted to positive after culture conversion among these 98. This is a reversion rate of 3.1%. The time to reversion from conversion was in these 3 patients 1, 5, and 6 months. And we also look if how many deaths we had during the period of reversion to see if this could also maybe explain a lower reversion rate. And there were 3 deaths during this period of reversion. So in conclusion, we have seen in our cohort of patients favorable conversion rates with very high conversion rates in these patients that are most of them exposed previously to second-line drugs that are very sick with extensive disease, bilateral disease with high resistance patterns. So these are very promising results. We have seen that in the subgroup of HIV-positive patients, the lower conversion rate seems to be driven by the early death in this population, who you have seen had low CD4, and for some of them they were recently diagnosed. Regarding reversion, the proportion is low, so again that shows good results in this cohort. And we need more data to see, to identify risk factors that could be linked to the reversion and see what could explain reversion in these patients. We like to look at the role of extended use of bedaquiline for more than 24 weeks, concomitant use of bedaquiline and delamanid. And we are planning to do further analysis this year, so we'll have more results by mid or end of this year. Thank you very much.
Good afternoon, dear colleagues. I would like to welcome you all in this hospitable land, and I would like to give the floor to the next speaker, Ms. Nino Lomtadze, Head of the Department of Oversight and Strategic Planning of the National TB Center and Pulmonary Diseases from Georgia. This is a presentation on the adverse events of interest and serious adverse events, the ENG TB.
Thank you very much. I want to thank NTB Project for providing this opportunity to let me present the whole NTB safety data. So let's start directly from the methods. The methodology that was used for collection of data is methodology that is used within the NTB project. These are a collection of all serious adverse events and also adverse events of special interest. The data are reported and collected by the Geneva Pharmacovigilance Unit. The non-serious adverse events are adverse events of special interest, adverse events that has led to change in at least one drug in a treatment regimen, and any other adverse event that were considered clinically important. Causality assessment was done in a very conservative way. We were not using any detailed algorithms, so it was considered to be related to the drug if there were no other exclusion for causality, and not related if there was a definite cause for this event. So this is pretty simple approach for causality assessment that needs to be taken into consideration when we will be presenting the causality data. Other assessment includes the treatment outcomes, outcomes of the adverse events, other causal factors, and also the final action that were taken with regards to the adverse event. Also, it should be mentioned that all pharmacovigilance sites where the safety data were collected were trained by the NTB-PV unit. The flow of the data were as follows. So this was post-marketing and observational study. So as mentioned, we're collecting non-serious adverse events and serious adverse events. Serious adverse events were directly reported to the Geneva PV unit, while the non-serious adverse events were first entered into the clinical information system, so-called EMR, and then also reported to the Geneva PV unit. Once in a quarter, the Geneva PV unit provides reports, quarterly reports for serious adverse events. These are the ICSRs, and for the non-serious adverse events, these are the quarterly reports on those events. And it should be mentioned that in addition to the adverse events, the data on pregnancy has also been collected. So how I describe the serious adverse events? So we all know that these are the adverse events that cause death, that cause hospitalization or prolongation of a hospitalization, that are life-threatening, that cause disability or some significant disability, and other congenital malformations in the newborns or fetuses of the patients or partners of the patients taking the drugs. So the data for the serious adverse events are solely entered in the pharmacovigilance information system that is located in Geneva PV unit, but for other non-serious adverse events, the data are entered into the EMR. So what is the list of those non-serious adverse events of interest? So these are the peripheral neuropathy, myelosuppression, QTc prolongation, optic nerve disorder, hepatitis, hypothyroidism, hyperkalemia, acute kidney injury, and ototoxicity. So when we talk about the adverse events of interest, this is the list of events that we've been focusing on during the NTB observational study. The study population, these are the patients who have started treatment with bedaquiline and or delamanid between 1st April 2015 through October 2016. And this, the adverse events that we were looking at are those adverse events that have been revealed between the start date of the new drug within the first 6 months of this new drug exposure. The characteristics have already been presented by Helena, but this is clearly the different cohorts. So there were a total of 687 patients, and we see that majority of them were male. 36% had less than 18.5 BMI, and 80%, more than 80%, had extensive bilateral tuberculosis disease. From the point of view of resistance, we see that this is not an easy cohort. So almost 65% have fluoroquinolone resistance if we sum up the pre-XDR and XDR cases. And also among these, 40% almost were XDR TB patients. Around 12%, around 17% were HIV positive. 12%. I'm sorry, were HIV positive. More than 16% were hepatitis C co-infected. Diabetes was revealed in 10% of patients, and almost 70% of those patients have been previously exposed to the second-line drugs. So let's focus on the presenting of the adverse event of interest, and then we will move to the serious adverse events. So adverse events of interest. 503 out of these 687 patients, which is almost 73% of patients, had at least one adverse event of interest. And we are talking about those 9 adverse events that was presented in the previous slides. For those experiencing adverse event of interest, median number of adverse events per patient was 2, and the range of adverse events per patient was varying from 1 to 14. So there were patients who have experienced 14 adverse events of interest during the 6 months of treatment. So because the observation period for us is 6 months of treatment, it doesn't mean the treatment was lasting for 6 months. So these are the adverse events of interest that our patients have experienced, and we see that the top position is by elevated liver enzymes. So the first column here shows the number of patients with at least one adverse event of interest. The next column is number of patients who have experienced at least one adverse event of experience, but with grade 3 or 4 severity. And then we see in the last column the adverse events of interest that had pending outcome or not resolved. So we see that almost 30% of patients had at least one hepatitis adverse event, and but much more less had grade 3 or 4. Prolonged QTC prolongation, 24% of patients had at least one event of QTC prolongation, but very few, 1.2, were grade 3 or 4. Also anemia, 18% of patients had at least one event of anemia, but less, 2% of those were grade 3 or 2. So if we'll go down the events, we'll see that adverse events of interest, they are frequent. Overall, more than 84 patients have experienced at least one adverse event of interest, but very few of them were grade 3 or 4. So now let's move at the severity grading of those adverse events. As expected, we see that majority of them are grade 1 or 2, and also majority of them has been resolved. Also the drugs, the intervention regarding drugs that were undertaken in most of the cases, drugs were not withdrawn from the treatment. They were preserved within the treatment regimen. And in only few cases, which is 6.8%, the drug, we are not talking about bedaquiline or entolimod, any of the drugs were, or some of the drugs were suspended from the treatment. Now let's move to the serious adverse events. Overall, within this observational period, we have observed 136 serious adverse events. 109 out of the 687 patients, which is almost 16% of our patients, had at least one serious adverse event. And this is within the first 6 months of treatment. Out of these, 12.5% had one serious adverse event. 2.8% had 2 serious adverse events, and 0.6% had 3 serious adverse events. If we calculate the incidence of serious adverse events within this cohort, it would be 3.5 per 100 patient months. Now let's look at the 10 most common serious adverse events. Again, increased liver enzymes are the first in this list. Number of patients who has experienced at least one SAE of hepatitis is 3.3. A number of patients who had experienced grade 3 and 4 are 2.8. And number of patients who had fatal outcome for hepatitis SAE are 0. QTc interval prolongation. Number of patients, percentage of patients experiencing at least one QTc prolongation, which was qualifying the seriousness criteria, was 1.7. 1.4 had grade 3 or 4, and again, 0 deaths due to QTc prolongation. Anemia. Respiratory failure. 1% of patients had at least one event of respiratory failure, and also 1% of patients had grade 3 or 4, and 4 patients died, which is 0.6%. Cardiac failure. So we see that 1% of patients had both at least one event and grade 3 or 4, and 5 patients had fatal outcome. Infections, other infections, we see that around 1% of patients had experienced infections as a serious adverse event, and 3 patients had fatal outcome. TB disease progression, we see that 0.5% of patients, which are 5 patients, has experienced the SAE due to TB disease progression, and all of them, 5 died. TB death, and we say death when this is an observed death by a medical person and patient died at home, or the reason for death has not been depicted. So death was in 4 patients, 0.5%, myocardial infarction in 4 patients, and also 0.5%, and vomiting that was qualifying the seriousness criteria was in 0.5%, only 0.1% was grade 3 or 4, and of course 0 deaths due to vomiting. In the previous slide was providing information per patient. I mean, the percentage and number of patients who have been experiencing those serious adverse events, but we will now look at just at serious adverse events, not the proportion of patients. Increased liver enzymes was 19% of patients 19% of all serious adverse events were increased liver enzymes, 8.8% of all serious adverse events were QTc prolongation, 6% of all serious adverse events were respiratory failure, 5.1% anemia, 4.4% infections, 3.7% TB disease progression, 2.9% myocardial infarction, and 2.9% of all serious adverse events were vomiting. Now let's look at the outcomes of these 139 adverse events. So we see that unfortunately 30% of those serious adverse events had fatal outcome. 6, which is 4.4%, have not resolved. 47, almost half, of serious adverse events has recovered or resolved. Around 11% resolving by that time when we were making the observation. 5.5% has been resolved with sequelae, and so this makes total of 133 patients, and there are not available outcome data for 3 serious adverse events. So we see that there were 36 patients who died, but those 36 patients has experienced 41 fatal serious adverse events. So now let's look at some possible causes of those serious adverse events. So there were 136 serious adverse events, out of which around 93 were considered to be related to anti-TB drugs. We don't say dilamanid, bedaquiline, any anti-TB treatment. And it is possibly related, this should be mentioned. We are not talking about definite relationship or causality. We are talking about possible relatedness to anti-TB drugs. And 43 has not been considered to be related to anti-TB drugs. Out of these 93, 19 were fatal SAEs and 74 were non-fatal SAEs. Out of the 19 fatal SAEs, for 9 SAEs, it was considered that there is possible relation to bedaquiline. For 3 patients, it was considered that there is a possible relation to dilamanid, and for 7 patients, it was considered that there is a possible relationship to other non-anti-TB drugs. Also, when we say possible, this means that there was no other definite cause of this fatal SAE, but there were other factors that might have contributed to this fatal SAE. That means possible. That we cannot say like definitely no. We can't say no, but we can't say yes, but it's possible because there are other factors that have been that has contributed to these fatal SAEs. In 8 patients, it was TB disease, progression of TB disease. In 5 patients, it was hepatitis. In 1 patient, it was HIV. And in 6 patients, these were other non-TB drugs. And when we say non-TB drugs, we mostly mean the beta blockers that have been used for prevention of QTc prolongation and arrhythmias within patients, which is not allowed to be used was not allowed to be used within this NTB cohort of the patients. I will not go in detail for those SAEs that were not considered to be related to TB drugs, but the other causal factors here again were TB disease, hepatitis, HIV, alcohol intake, other drugs than TB, and etc. Now let's focus more on QTc prolongation of more than 500 milliseconds. So we see that there were a total of 15 QTc prolongation of more than 500 milliseconds. And with symptoms, there were only 2. When we say with symptoms that it was not just prolongation of QTc, but the patient had his signs and symptoms of arrhythmia, syncope, or something like that. 13 patients had QTc prolongations without any symptoms. The outcome of these prolongations in 14 patients were resolved, and there's only 1 patient where it has not been resolved. The possible relationship to anti-TB drugs, it was considered that 13 out of these 15 were possibly, again, related to the anti-TB drugs, especially bedaquiline and dilamanid. But despite that, in 10 out of these 15 QTc prolonged patients, drugs have been preserved. They were not suspended or withdrawn from the treatment. In only 2, the dose was, in 3, we don't know what was the action made towards these drugs with regards to QTc prolongation, but in only 2 patients, the drugs were withdrawn. So, to conclude, overall, the NTB team has really observed a very good reporting of serious adverse events and adverse events of interest within their cohort. Adverse events of interest, we see they are very common. 84% of patients have experienced adverse events of interest, but very few of them were grade 3 or 4, and majority of them has resolved. And the drugs that were mostly causing those adverse events of interest were linezolid and injectables mostly. Fetal SAEs often have other contributing factors, such as comorbidities, as we have discussed, tuberculosis progression, other non-TB drugs, such as beta blockers, etc. QTc prolongation was reported frequently, but very seldom. It was over 500 milliseconds. Very few cases had symptoms associated with QTc prolongation, and none were fatal. Also, raised liver enzymes are pretty common adverse event of interest, and also serious adverse event that requires additional attention to comorbidities, and more analysis needs to be done with these regards. Thank you.
Thank you, Nino, for excellent presentation. Следующий доклад расширенное использование новых противотуберкулезных препаратов.
Drugs, ergobulan, alvikojin, partners for health. Good day, dear colleagues. Today I will be speaking about our expanded use for medication. So we're talking about off-label use of those non-recommended by WHO. Okay, expansion to new drugs expands. So more often we select new anti-TB medication. More often we using new medication like bedaquiline or delamanid. However, there is a need that we face more and more, that some patients, of course, considering all the risks for the patients, for some patients, the use of this medication is necessary to be used for more than 24 weeks. Sometimes both the bedaquiline and delamanid need to be used at the same time. We also, as previously was mentioned, we need to use it among children and with pregnant women. So analysis have been conducted in the group of, in subgroups of 687 patients who have started at least one drug, bedaquiline or delamanid, in the period from April 1 to end of October year 16. Why do we have to use bedaquiline or delamanid more than 24 weeks? This is because this is when we see that patients does have response on the treatment provided, but sometimes the time frame is not enough, and we haven't yet identified either success or failure. It's not failure yet, but if we see positive tendency, like Mycobacteria number in the samples decrease, we see positive dynamics, but at certain period of time, within 6 months, the conversion haven't occurred yet. Then in that cases, this continuation, prolongation is possible. Or sometimes there have been cases when after the cancellation of bedaquiline and delamanid, there are no other drugs available. And it's necessary to keep those medication for the follow-up regimen. The 32% of the patients, which are 223, were receiving more treatment for more than 24 weeks. Okay, 70% received bedaquiline only for a longer period. 17% it's delamanid, and 13% of the patients, which is 28, have been taken both bedaquiline and delamanid at the same time. Well, characteristics of the cohort shows a general level the burden of the disease. These are mostly men, 65% average age 36-year-old, So we talk about the workforce, working population, body mass index, and resistance pretty much the same. So it's MDR or XDR, which sum up the total of 70%, and XDR about 50% of the patients. Comorbidities, co-pathologies. So these demonstrate a level of the burden disease. So we see some patients had a co-infection with HIV, 16%, Hep C, 11%, diabetes, 8% of the patients. And the majority of the patients, of course, were previously receiving second-line drugs before. Well, Nino have told a lot about of adverse events that have been mentioned. So in this cohort, we also have seen liver enzyme increase. So it's 24.4% cases, and serious adverse effect 5.4%. So EQT interval increase amounts to 16.9 and 2.6 with the severe cases. Peripheral neuropathy and acute kidney failure, you see it at 5.9% cases. Well, considering that patients will receive 6 and more months and using treatment of co-infection, it does affect. That's why all adverse effects have been registered. Total number of the adverse effect was 17 in case of 0 to 6 months of treatment, and 20 in case with those patients who were treated more than 6 months. So, and you see electrocardiogram, corrected interval 3 and 1. Accordingly, liver enzymes, we only had one case. Combined bedaquiline delamanide, there were 46 patients using both or combination of the two drugs. 22 patients, which was 48%, started delamanide and bedaquiline combination within 7 days, almost simultaneously, and 52%, a little over the half, started taking delamanide and subsequently bedaquiline. When regimen was corrected or adjusted with bedaquiline in 75% of cases, or delamanide was added later at 25% of the patients. A reason why the regimen was changed is related with the increase of the spectrum of resistance, drug resistance, and personal issues and other reasons. So in principle, the cohort characteristics is pretty similar to the general cohort, so I won't enumerate all the details, but I want to talk about so resistance. Resistance with MDR patients, it's only 9%. But over 80% of patients, these are patients with XDR and pre-XDR, which are patients which have no choice for efficient regimen of treatment that had to use combined two medication.
And then comorbidities, of course, that also has a reflection on the overall picture. So conversion with combined use of bedaquiline and delamanine in 6 months, 46 patients with concomitant use. Of those, 22 patients, or 48%, started bedaquiline and delamanine at the same time. That means approximately 7 days was the difference between their intake of the drugs in the algorithm. 11 or 50% with a positive baseline culture. Out of those, 8 converted. That's 73%. Efficacy and safety of combined use among patients. So these are the adverse effects that have been recorded, such as the prolonged and corrected QT interval. That's 9 patients, 24%. Of those, only one in grade 3 or 4. Increased liver enzymes, 8 patients, no advanced stages. Peripheral neuropathy, also 8 cases with 0 extreme cases. Thank you for your attention, and to sum up, let me tell you that this transition to individual regimens, the abolishment of the standard regimens, the expanded use of new drugs, all that means that we're currently using the off-label approaches because this is also part of the patient-oriented approach. We don't have a standard approach towards each individual patient saying this is the only regimen that you have to follow, although we only have, for instance, a few XDR patients, but they're all different from the point of view of their resistance spectrum. It sounds about the same, XDR, but the spectrum of resistance is different, and that means that we have to take a look at what they've been on drug-wise previously, what are they resistant to, what are they tolerating, what are they not tolerating. So in order for us to accomplish a certain treatment result, we have to pay attention to the efficacy of the algorithm that we prescribe. And quite naturally, WHO recommendations are also important, but if we are afraid of using drugs outside of the recommendations, then where do we get new recommendations from? How can WHO come up with something new if we don't do it in the first place? So this must be done. Thank you for your attention. I'd like to give the floor to the next, Dr. Bern Yangwa, MSL Great Britain, the experience of clinical studies of TB practical clinical trial.
Okay, thank you for inviting me to speak at this forum. So I'm going to talk about TB practical trial. Some of you would have heard about it before, and I'll just try to go through some of the first parts of it, which is just describing what the trial is all about, and then at the next towards the end, I'll just talk a little bit more. Okay, all right, thanks. Then I'll talk a little bit more about other areas that may not have been discussed in previous conferences. So TB Practical is a randomized, controlled, open-label phase 2-3 trial for MDR-TB. We use pretormanid, bedaquiline, and other drugs for developing these regimens. So we have 2 main goals for TB Practical as a project and specifically for the trial. And the first goal is to try to identify new regimens for MDR-TB that are radically shorter. So we're looking at 6 months in duration. We're looking at trying to see these regimens, if they will be tolerable and hopefully also as effective. And one clear important aspect of this is also to try and see that if these regimens actually can be more appropriate for scale up. But one of the bigger difference, and it's going to be the same in the next presentation about the trial, is the standards that we want to use for this trial. And our standards are put at in ICH GCP standards, which are the regulatory level for clinical trials. So these are really stringent regulations or stringent quality of the implementation of this trial. A lot of developers would focus on their clinical trials on regulators like the FDA, the EMA, or the regulators in their countries. Our primary goal is to target the WHO's guidelines development committee, and in that light we've had to discuss with them, and some of the decisions that we've made with regards to the design of TB practical trial has been in relation to what they feel is relevant. And since we're talking about the patient-centered care, I think for practical we have objectives that we want to see and achieve in terms of the success and so on. But what we feel is also quite critical is to look at what potentially could happen. And if we look at the number of tablets and the injectables that patients take when they're the current MDR TB treatment and what we provide for practical, that clearly is there is a clear difference in that. But of course, this is what is seen by the patient today in the trial. What we need to try and see is whether these fewer tablets that or oral as a regimen actually would make a difference in the outcomes. So we have 3 arms in TB practical trial that are as investigational arms, and then we have 1 arm which is a control. All 3 arms, which are in the investigational arms, are 6 months long. The first one has bedaquiline and pretomanid and linezolid. The second arm has the same backbone, but we add in moxifloxacin, and the third arm has the same backbone with the addition of clofazimine. We define the control arm as a locally accepted standard of care, which is consistent with WHO recommendations. Of course, that means that depending on the country, we might have the control arm that contains the 9 months shorter regimens, or we might have a control arm that contains 2 years. And if the patient requires new drugs like bedaquiline or delamanid, then the patient in the control arm can actually access those drugs. In fact, with the recent WHO recommendations opening up for the possibility of extending beyond 24 weeks, or considering the combination of bedaquiline and delamanid, we also, on a case-by-case basis, accept that as an option for patients in the control arm. So just to give some updates, so there has been a lot that has been achieved to get to where we are, and in this room there are plenty of people who have really worked so hard to get to where the trial is, but we clearly also have a long way to go. So our target recruitment is to have 630 patients in the 2 stages of the trial. As of the 15th of February, we had 65. Practical is planned to recruit in 4 sites in 3 countries. Our first site was in Karachi, Pakistan, and they started recruiting in the beginning of last year, and it remains our biggest site right now, who have recruited at least 61 patients. And we have a site in Minsk, which has recently started and doing quite well, I'd say, with the 3 recruited patients so far. And Animesh was telling me that number can change quite quickly. So we're looking forward to that. And we also have a site in South Africa that has recruited 1 patient, but we started off in a sub-site, and our main site in South Africa is meant to start recruiting in the next couple of weeks. and we are still in the process of setting up the site in Tashkent, which we expect to start recruiting in the second quarter of this year. Probably where I'm going to focus a little bit more, apart from what has been known in the past, are the opportunities that we see with developing TB practical trial and its implementation, and later on the challenges that we have faced. So implementing a clinical trial involves a lot of investment. There's a lot that we've invested in terms of staff, in terms of systems, and therefore it is we feel and had planned before we started the main trial that it is relevant to have sub-studies that not only provide information about the outcome of patients overall, but also that look at very specific areas. So one such study is the population pharmacokinetics and pharmacodynamics study that we're going to do in the TB practical trial. What is a bit sad, I would say, in TB is that there is very little that is known about the pharmacokinetics and pharmacodynamics of the drugs that we use. There is some information, but that is really very limited. And just to mention that, I don't know whether we actually have a pointer. Yeah. So what I just put up there are the what you would see if you give any of the drugs to a patient and then you continuously measure the quantities of the drug in their blood, and all of these are just showing the what you would expect. So the concentration will increase and then will drop. The lines are just demonstrating where the next dose is in relation to that concentration. And the drugs that we give in MDR-TB are so different, and some of them have quite strange, I would say, pharmacokinetics, like bedaquiline, which, if you see the example there, it's a lot. You give the first dose and the second dose, and most of the changes in the blood happens after the first dose because it has a long terminal half-life. So we felt that it is an opportunity to actually look at this further. So maybe just to mention, some of these words might seem complex, but pretty much pharmacokinetics just refers to what the body does when you give the drug to what the body does to the drug when you give it. So in this sense, it will absorb the blood, the drugs. They will be distributed, and some of it will be metabolized, and some of it will be excreted from the body. So that's just what we talk about when we describe the pharmacokinetics. And from the pharmacodynamics aspects, it's just what the drugs then do to the body, or they do to the TB bug. So pretty much we're just talking about the same aspects as what happens when you give the drug to the bacillary load, for example, or what happens with all the side effects that result when you give these drugs. Some of the things that I refer to that we don't know are actually the dosing. So if I ask most of you who use, for example, clofazimine, what dose you give to your patients, you probably would find a couple of different guidelines in here, whether you give 200 or 300 up front and then reduce to 100, or you give 100 and so on. In practical, we're giving 100 for most patients. Potentially, if the patients have a lower weight, we'll give 50 milligrams, but we're giving 100 for most patients. And therefore, we're interested to understand, is this actually the dose that should be used moving forward? Does it actually accumulate enough in the patient's blood? It's the same thing with linezolid. Most of us, I know, we give 600 milligrams, but we also know that the actual label for linezolid is for 1,200 milligrams once a day. And some of you would also reduce it to 300 milligrams. Again, all of these things are unknown. There aren't enough studies out there that can provide this. And that is one of the reasons that we're doing this. Might sound strange, but even bedaquiline, now with the TB Alliance are looking at giving bedaquiline at a stable dose and not giving a loading dose and then a follow-up dose. So all of these things, we feel that there are opportunities to actually trying to look at what's happening with the drugs that we give. So even if the TB practical trial was not to show that these regimens actually work or they don't work, we feel that some of these opportunities need to be taken to then learn from them and try to move forward. So just quickly to mention that we are looking at a sample size of up to 240 patients, and one of the challenges with this is that we need to export the samples so that they can be done in a particular place. So depending on the countries that can allow us to export the samples, then we will do this sub-study there. And maybe just to mention, we are still looking at other things that can be learned. We're looking at some of the pharmacogenomics aspects to look at is this drug working because of some of the genetic makeup of a particular individual, and we all have various differences in there, and we're going we'll have a look at that. We're also going to look at other ways of doing the pharmacokinetics a bit easier, because the classical one, you need to take the blood sample, spin it, and store it minus 80 and so on, and we're also trying to see if we can use microcuvettes to have dried blood and do the pharmacokinetics, as well as if we can look at including hair samples and look at the pharmacokinetics from there. Another one, which is maybe also much more focused to the discussion we're having at this conference, are the two kind of social sciences sub-studies that we're looking at in practical. The first one, which is a bit probably more represented by that kind of cartoon there, is a sub-study that we're looking at the tolerability. And for us, this is really what patient-centered outcomes are, and trying to see what do we actually know about the experience of our patients when they have been on these treatments. We tend to put up the figures of 80% success or 50% success or whatever success rate it is, but when a patient actually goes through the treatment and gets to the end, what do we know about the experience through the treatment? I'm sure if we ask two patients who have had the same treatment and have had both successful outcomes, they'll tell you they experience differently. So this sub-study is really just trying to understand the perceptions, the expectations, and the experience of patients, and really trying to see how the trial regimens that we're implementing either improve or impair their quality of life. Because they could still have a successful treatment, but some of them, their quality of life might actually have been affected. So this is part of the sub-study that we're looking at. The other sub-study is on the economic evaluation, which is looking at the cost effectiveness of the regimens. In a general point, we might not necessarily see that as patient-centered care, but in fact, this information is quite crucial. Some of the cost data that we'll use for these evaluations would include patient and household costs, where we talk about patients and we talk about how much they had to spend to get to the health facility, and how much money they've actually either mostly lost through the process that they have been on treatment. And we also look at event data, so trying to quantify what side effects or adverse events actually means to the patient in terms of costs. So we will look at these 3 sub-studies to try and learn from what we're doing in the main TB practical study. Unfortunately, there are major challenges that we have faced with regards to the TB practical implementation. I think one of them is probably most of the ones, especially those from NUCUS, would tell you is actually the workload. Just doing the clinical trial is a lot of work, and everybody is running 24/7, and we have to think about that and see how we can deal with that. But from the other aspect, there's also the challenges in terms of recruitment. So we recruit on average 1 in every 4 patients that we have identified. Of course, recruitment into a trial, there's a need for informed consent to be provided by the patient. There is no measurable direct benefit to the patient when they're joining the trial. Therefore, they have to volunteer to make sure that their involvement in the trial is for the greater good and not necessarily always for themselves. So having said that, we still feel that the fact that we end up with only 1 in 4 patients on the trial is quite a challenge that we need to think about. So because of this, we had an assessment, and I know I'm running out of time, that we did to try and look at what are the challenges and why this is happening, to really understand the reasons for patients' perspective, whether negative or positive, in terms of their willingness to engage with the clinical trial. This graph just shows that in general, the reason patients don't end up in the clinical trial, half of them is because we as a trial have decided, or the clinician or the investigator has decided that this patient is not the correct one to take into the trial. Those are half of patients, and half of the patients, and the issues about protocol and trainings we probably will discuss and trying to see what can be done in that area. But I'll talk a little bit a bit more about the decision by the patient not to join the trial. And this is something that we've tried to look at in NUCUS. And just to give, this is just the patient journey, and I know it's very simplistic. There are a lot of steps in the process to get the patient to start and join the trial, but this just shows that when we have a gene expert result, then the patient has a consultation between a trial and non-trial doctors, TB doctors, to see whether the patient is even interested to be informed further. If the patient is interested to be informed further, then they undergo a couple of counseling sessions, and if they agree, they sign the informed consent, and then they undergo the screening, and finally, if the screening results, there are no exclusions, then the patient starts the randomization into the trial. I think one key point that we have identified from this study is that most patients actually, so 60% in when they were reviewed in Pakistan, that 60% of the patients made this decision not to join the trial at the point where they were just informed that, will you be interested to be told a little bit more about the trial, which means they're making a decision from background expectations or background fears or other things, not necessarily having understood what the trial is about, what are the risks or benefit of joining the trial. So this is an area that I know the team is also working hard to try and see that the patients then have that information when they're making that decision. But this is also not just about the moment that they meet the clinicians or the moment they meet the investigators or counselors. This is also about the community. How much information is there about clinical trials or clinical research in the community? What are the positives or negatives that are out there with regards to that? Are there fears about new drugs, new treatments? Are those fears have they been explored and discussed a bit further? So I think there is a lot of work to be done, and hopefully, and this was not to show how it's not going great or anything in Nuku, so this is for us to actually try and learn from it, and I'm sure other sites could also learn from some of these issues. We had to do it in a hurry to get this information, so we don't have we did it as an operational step, not as a research. Therefore, we will not be able to publish it. But if people are interested to understand some of the details, because it was really detailed and well done assessment, we will be more than willing to share to try and see that the region can actually contribute to this fight against MDR-TB through also doing some of these clinical trials. And I would like to thank all our collaborators and definitely especially the teams on the grounds that have implemented the trial. Thank you.
Thank you. Next presentation, Dr. Lorenzo Guglielmetti, NTB, copy of clinical trial, experience results of NTB clinical trial.
Thank you very much. So first of all, I have to apologize for my voice. So I'm not sure I will get until the end of the presentation, in case I will finish talking with my hands. I also have to disclose something. Actually, I will not present any results. So I'm sorry, it was just a technique to keep you all here and not running to lunch. But please, so stay. I will try to make still an interesting presentation anyway. So we will go quickly through what is NTB, because I think most of you heard something about this trial. We will talk a bit more about the models of care in the different sites and the trial progress, as Bern did for practical. And we also have the section about challenges, of course. So you heard a lot about the NTB project. I just want to mention that the trial is what is called the second output of the full project, which accounts for more or less half of the total budget, and the sponsor of the trial is MSF. Yeah, it's not the same slide in English. Yeah. So NTB is a randomized, controlled phase 3 non-inferiority trial. The little difference that we have with regards to other trials is that randomization is adapted according to this Bayesian methodology, which basically just means that while we get results on the efficacy of the different experimental arms throughout the trial, the patient will be more likely to be assigned to experimental arms which are performing better. And the idea is really to identify not just one non-inferior regimen, but as many as possible. And this is a little bit the philosophy behind the trial, because we think that just one single regimen is not enough for all patients, because every patient is different because of comorbidities, drug-resistant pattern. In NTB, we test 5 experimental regimens of 39 weeks or 9 months of duration against the conventional standard of care control arm. In a population of patients with pulmonary tuberculosis, which are resistant to rifampicin and susceptible to fluoroquinolones, and with a total sample size of 750 randomized patients. So the endpoints, I just want to show it here. So this one at 73 weeks is the main endpoint and the main outcome of the trial, because we choose 73 weeks because, as you can see, if these 5 are the experimental arm, from 1 to 5, they all end up after 9 months, and you have this lapse of time of approximately 6 months when we will observe if there are any early relapses in the experimental arms. We will also assess other outcomes at safety and efficacy after 2 years, or 104 weeks of total follow-up. And we have early outcomes at 8 weeks and at 39 weeks, and these are the outcomes that will actually drive the adaptation. So I will skip through the inclusion criteria that we mentioned before. I just want to mention that the susceptibility to fluoroquinolones and resistance to rifampicin, it's all detected with rapid molecular testing, and then we have the phenotypic DST that comes after, and eventually excluding patients in a second moment. And exclusion criteria are also quite standard for trials. I just want to mention that we exclude all patients with exposure or proven resistance to new or repurposed drugs like linezolid or clofazimine during the 5 years, the last 5 years, and also patients which have been exposed for more than 2 weeks to a second-line MDR-TB regimen during this current treatment episode. And so these are the 5 experimental arms. As you can see, there are some common points. So all the experimental regimens contain one new drug between bedaquiline and delamanid, and treatment arm 3 contains both of them. And then we have one repurposed drugs between clofazimine and linezolid. And we always have fluoroquinolone, of course, because we are talking about fluoroquinolone susceptible strains. And the fluoroquinolone can either be moxifloxacin or levofloxacin, according to how many QT prolonging drugs are present in the specific regimen. And then we have pyrazinamide that we have added in all the treatment arms. And the treatment arm 6 is the standard of care, which is composed exactly like in practical, according to WHO guidelines. So it can contain bedaquiline or delamanid or even both if it is needed. So these are the 6 countries which are taking part to the NTB trial. So as you can see, this region is really the epicenter of our study. So far we have started first in January 2017 recruiting patients in Georgia, in Tbilisi. Then we have activated 2 sites in Lima, in Peru, and 2 sites in Almaty, Kazakhstan. The 4th site that has been activated is Lesotho, and where we started recruiting last month. And we plan to start in the next weeks also in Cape Town in South Africa and in Osh in Kyrgyzstan. So I just want to talk a little bit about the different model of care, because this is something that can explain also why doing a trial in different countries is challenging. So in these 3 countries, for example, Georgia, Kazakhstan, and Peru, the model of care is quite centralized, since patients are included, randomized at the central TB hospital, and then follow-up visits and DOT, which is supervised by a nurse, or anyway by a healthcare provider, are given either at the TB hospital or at the TB clinic. Although there are differences between the different countries, because in Georgia everything is happening in the TB hospital. In Kazakhstan, actually, TB clinics are involved, and we are even thinking about implementing video DOT. And for example, the sites in Africa, so South Africa and Lesotho, have a very different model of care. Yes, patients are still enrolled in the TB hospital or in a TB clinic, but the follow-up visits can be done also in peripheral health facilities, which actually do not usually follow TB patients. And DOT is done with the treatment supporters, so with somebody who is trained to follow up the treatment with the patient and administer the treatment at home. And what about Kyrgyzstan? So the idea in Kyrgyzstan is to start in recruiting patients in this red part of the country, which includes mainly two sites, the city of Osh, and this big red area, which is the district of Karasu. So the idea is still to have a centralized entry point from the patient that will be randomized and perform all the follow-up visits at the TB hospital in Osh, but then the treatment will be administered also at the TB cabinets and potentially also at the other peripheral healthcare facilities. So there have been quite a few steps that have been undertaken to make the trial happen in Kyrgyzstan. So we have received approval from the bioethical committee, and I want to thank our chair for that. And we have done multiple preparations to prepare the site in Osh TB hospital. We received a medical accreditation, a local IRB has been established, and a good clinical practice training has been performed for the staff on site. MSF has contributed in renovating the MDR and especially the XDR-TB ward and the intensive care unit as well. Local site standard operating procedures have been developed, and we have had assessment to obtain the clinical trial site license in February. But still, we are not there yet, so we are waiting to obtain this clinical trial site license in the next days, probably, and after that we will be able to apply for the final DDP regulatory approval. And once we have the approval, we will be ready. We will just need to perform the final training and the site initiation visit. So a few words about the progress of the trial. As of February 13, we had more or less 50 patients, as you can see. So the main bulk of patients are coming from Peru. Georgia is contributing substantially to this number, but as I pointed out before, Georgia has been started really early in recruiting patients. So since the recruitment rate has not reached our goals, we actually took the decision to stop the enrollment of patients in Georgia during last month. We will go on, of course, following up those patients, and we will go on recruiting patients in Kazakhstan, which is the third site in order of recruitment, and in Lesotho, where we just have had the first patient last month. And as I mentioned before, we are hoping to start in Kyrgyzstan and in South Africa as soon as possible. And this is the general picture, just to remember, as Bern did before, that 50 patients is not much when you want to reach 750. So this is the line. This is our goal in terms of recruitment, and the black dashed line is our actual situation. So we are a bit lagging behind, and so that's why we are considering corrective actions like opening new sites in the countries which are involved, and also exploring new sites in new countries. So with the corrective actions, we are confident that we might anyway be able to conclude enrollment as planned by the end of 2019 and have the first results in the beginning of 2021 for the primary outcome and the end of the follow-up 2 years after the end of enrollment. So, as you may have realized, we encountered some challenges too. So, first one is my voice today. The one challenge is the change in somehow unpredictable changes in the secular number of MDR-TB patients in some countries. This is definitely the case of Georgia, for example. We encountered, of course, some regulatory barriers in all of the countries, and this has slowed down a little bit starting the sites. Rates of patient refusal is a problem that we have found as well, especially in some countries, while in other countries, like for example in Peru, there is a lot of enthusiasm about injectable-free regimen. DOT decentralization is a challenge when you are providing 7 days a week DOT like we are doing, and also twice a day for patients receiving the Lamanid. And as Practical is doing, we are also accepting the short course regimen as a standard of care in the control arm. And finally, of course, the variability across all the sites is something that very, very important to take into account. And I just want to mention that we are also performing some sub-studies. So we have our PK/PD sub-study too. It's funded by the Wellcomes Trust, and the PI is Anna McKilleran from the University of Cape Town in South Africa. And basically, it has the same objectives that Bern explained before. And I also want to mention that as a consortium, the NTB consortium has applied for funding through Unitaid for another trial called NTBQ, which is in every means just the complement of NTB, which aims to include rifampicin, but also fluoroquinolone-resistant patients. And it's a very, very similar design. The goal is to test one single regimen. This one, bedaquiline, Lamanid, clofazimine, and linezolid against the control arm, and probably testing different durations of this only regimen. And let me finish by thanking you for listening, and thanking at least some of the very big central team. I'm doing this presentation also on behalf of the other co-principal investigator, Carol Mitnick of Harvard Medical School. I want to thank the co-investigators, the protocol writing committee, and of course all the site principal investigators, so the ones that actually do the job on site. So we have Dr. Nana Kiria, who is chair of this session. For Kazakhstan, we have Kanat Kajidinov, who is present here, the study coordinator. And we have our PI for Kyrgyzstan, Dr. Ulanbek, and also our study coordinator, Arnaud Samiev. So thank you very much for the work. We really hope that we will start soon in Kyrgyzstan. And thank you very much.
Thank you for your great presentation. Unfortunately, we have almost no time. But however, if you do have questions, please ask. I think so far this was one of the most interesting sessions. Right now, I was expecting that many questions.
Thank you for all the speakers for the wonderful presentations. I would like to ask to the first presenter if they have information about resistance to beta-acquylene and delamanid, if they have some information that make us concerned or relaxed for the new baby programs.
Yeah, thank you for the question. Yes, a very good question. I think it's the question we are all asking ourselves. So one of the one of the objectives of the NTB observational study is to look at acquisition of resistances. So this, we hope this will be answered within the study. So we are going to analyze isolates of patients at baseline, taken at baseline and taken after any positive culture after 4 months of treatment. And we will be following up these patients to do this analysis and see if there is any acquisition of resistance a long time.
This is to Bern. You talked about PK/PD, right? And we do all these studies before the trial. Is there any chance or any thoughts of doing therapeutic drug monitoring during trials?
Okay, thanks for the question. As just reflecting on what's feasible and whatnot, I think it's possible, but I have to say in the setup of at least the TB practical trial, it's not feasible because of the time lags between having to collect the samples and getting to the right place that actually can do the quantification. What the reason we're using a population pharmacokinetics approach for us is really because this allows the data to be modeled in such a way that you could ultimately be able to look at individuals and try to differentiate what covariates or whatever changes that are related to individuals might have affected the level of the drugs in their blood. But I think and the other kind of components we were doing, looking at hair samples and dried blood, might be the ones that could actually become useful in the day-to-day management of patients. But yeah, next.
Just еще вопросы.
Hello, yes, I have a question. It's for Bern and for Lorenzo, actually. So since this symposium is about patient-centered approach, and you both seem to have difficulty to recruit patients, and one of the reasons seems to be that it's not very patient-centered to be in a clinical trial, hospitalization, DOT, center-based DOT, not home-based DOT. And since we see a real progression, I think even today we've seen really people talking about offering patients better patient-centered care, which could be decentralized care, non-hospitalization, home dots, video dot. How flexible are you in the clinical trials to be able to change the model of care to give a better patient-centered approach Because I think what you said, Bern, to give this region possibility to contribute to the development of new regimens is really important in the participation in clinical trials, because I think this region has a particular epidemiology, so it certainly needs to be well represented in clinical trials too. So is there flexibility if countries are open to better patient-centered care to adapt the clinical trials to that?
Okay, I'll start and then maybe we'll go. For us, absolutely. I think so. I can say that our next version of a protocol, we will remove the need to hospitalize patients. So the next time we say, again, it has to be understood, as you rightly said, that the region and the countries and the systems have to make the decision. What we will remove from the protocol is the need to hospitalize, but then every hospital, every site will have to decide whether they can actually do that, whether they can send patients home or not. And the other one, which is already there from our perspective, when patients have been discharged from the hospital, for example, in South Africa, the approach is one that the patients can actually take the drugs at home with a treatment supporter. It doesn't have to be a clinical person, a nurse or something. A treatment supporter can provide this at home, but then we have kind of a safety net that they still need to be seen at least once every 2 weeks. So there is some flexibility if the systems can allow them to do that. But I also take the point about video dots, for example, which could be another option, which we definitely need to reflect a bit more on now that there is stronger evidence on actually swapping that with what we do.
So let me just have a brief comment, sorry. So it's a very good point. I think that actually the trial potentially could even be opportunity to push for innovation in this patient-centered approach, because you have much more means that what you have in the program. In NTB we don't have any obligation for hospitalization. We are accepting, of course, the treatment supporter care, which is normally given in a few countries. But we can do more for sure. And for example, in Kyrgyzstan, there have been discussion. The model of care is not defined yet, but there are discussions to implement, for example, treatment supporter care, which would be probably something quite innovative in the region. So I completely agree.
Спасибо большое за презентацию. У меня вопрос к Нино.
Thank you for the presentation. I have a question to the Nino and maybe other presenters as well. You mentioned one of the reasons of adverse events that too many medications were prescribed. What would be your recommendations to prevent that? And general active monitoring of safe drugs. In one case, if you have a trial, clinical trial or operational trial, but what will be the programmatic recommendations on active safety drug monitoring? Thank you. I apologize for that. Thank you for your question. Well, I didn't understand the first part of your question. You mentioned adverse effects being caused by too many drugs. Was that correct? Well, in one of the slides, you mentioned that there have been several drugs were prescribed at the same time, and there has been some interaction of drugs that could bring to the worsening of situation with the condition of a patient. I think that was not about TB drugs. Yes, this is other than TB drugs. It's a contaminant use of other medication. Yeah, okay. In that cohort, mainly these were beta blockaders used. On our side, for example, and maybe in other countries this is the case too, since we know already that new drugs are QTC, they cause QTC extension, many doctors, just to make a prevention of those events, they prescribe to patients different medications, including beta blockators. And that's not always correct thing to do. It is recommended within TB treatment if there are no indications or if there is no continuation of QTC interval, and if there are symptoms not available like arrhythmia, treatment with beta blockators is not recommended in general. I mean, just for prevention of QTC prevention, it's not recommended to, by default, prescribe like vitamins. We keep prescribing vitamin B to our patients. At the same approach, they try. Let's use beta blockators to the patients wholesale, not to just to prevent extension. This is wrong approach, both from the point of view of safety of drugs, and secondly, this is a observational study. This will be what we can say confounding when we hide the other effect and we don't have a chance to reveal whether those medications can cause QTC extension if we keep giving them those drugs, because we won't see the results, because unexpected adverse events will take place, but we won't have the chance to define what was the reason for that. A second part of your question was about programmatic approach and what recommendations would be under programmatic. Well, WHO recommends active monitoring already, and over safety of TB drugs to all patients, included for the second-line drugs. Not only new ones, but all of the second-line drugs. In principles, the countries where these trials have taken place, as observational trials, ADSM is something that has been either already introduced or being introduced currently. So on a programmatic level, maybe in volume will be not that as compared to the clinical studies, but a WHO recommendation doesn't force us to select observation only serious adverse effect or of adverse effect of some interest or all of them. If country has a chance to conduct pharmaco observation and surveillance, good, do it for the whole thing. But if not, just you can organize, ensure minimum package. Minimum package, I mean tracking most serious adverse effect and have some data collected at least for that group. So it is recommended for the country group within TB programs to actively collect evidence, more data for at least minimum serious adverse effect for all patients, not only those at new medication, because you have to compare with something. Maybe older drugs, which we were using before, new ones, are toxic, and if we don't track this actively, we won't see this information. This will be lost evidence. May I add, please? May I comment, please, on that? Thank you. Thank you. You know what the situation is in many countries currently. Before the beginning of use of new anti-TB drugs, there was no quite active pharmacosurveillance at all in the first place. So when we now start treatment out in the regions, we start active surveillance and collect data and evidence. And it looks like the new medication have more evidence and they look worse than the previous one within the standard regimen, meaning that we now show all unexpected and adverse effects, which could have been with the previous ones, but not that much registered. And if you compare, previously it was not done, now it is done, and you have more data, but doctors can see that these drugs have a longer list of problems, and they have more. The patients might face and come through more adverse effects than the previous ones. And that's a mistake. If previously pharmacosurveillance would be done with the previous medication same level as the new ones, then you will have to compare. So active pharmacosurveillance need to be introduced anyway, not only for the new drugs. Dear colleagues, thank you for the great presentation. May I tell you one thing before I ask a question, please? A patient, we talk about the patients, gets a treatment, but in the course of treatment, the conversion doesn't happen. To our lab, clinicists come to us and ask a question: what should we do? The isolate is sent to the reference lab into Germany, where the transportation of only 3 samples, just transportation, cost around $1,000. Not speaking of the cost of the tests that have been conducted there in Germany. So, I want to ask you a question, Dr. Demetsi. Your project works in several countries. I expected, but I didn't hear from your speech that in your large project you have one point, strengthening laboratory capacity with a bedaquiline or other new drugs, which means strengthen capacity of labs to conduct tests for bedaquiline lamanate sensitivity. After projects are over, after clinical trial is over, what should country do? A country do? What clinicists would do and what labs would do? Because a project is quite substantial, $60 million spent for this project. Could you allocate small amount of money to strengthen capacity of local labs? For that will be just great thing. Thank you so much. Colleagues, good day. Natalia Litvinenko, National TB Institute, Kiev, Ukraine. I have a question about off-label use. And this may be the question to Dr. Algozhin, first of all. You have a quite big experience with that. Could you please tell what should be the length of label use? Of use. Are you prolonged treatment for 20 months or from some specific time, or you have any differentiation? I mean, over 6 months use. 20 months, 9 months, 12 months. What's your recommendation? And what if there are different time limits? What should be the recommendations? Well, thank you. We don't have that much experience. In Kazakhstan, well, I present Kazakhstan, Partners for Health. We started treatment in Kazakhstan 17th of February, year 16, which is only 2 years by now. So average extension took place, but then 9 to 12 months. There are few patients with a spam resistance with absolutely no chance to get that previously prescribed drugs, on the few ones. I can't give you all the statistics. I haven't been preparing this statistic for this conference, but average time we actually extend up to 9 months, sometimes 12 months. Over 12 months is rare cases. We focus more. If you take standard division between intensive phase and follow-up phase, our follow-up stage is just to avoid recidive, relapse, and against failure. But active process does take place no more than 12 months. I mean, if we fail within 12 months, then it's a different story. But it's a very rare case when patients are kept more than 9 or 12 months. Again, conversion takes over 80% of conversion occur within first 6 months. Okay, thank you. A very small question in continuation to this one. main indication for off-label use? Is that when you don't reach desired result within 6 months, or the regimen is not effective? No. When the regimen is not effective, meaning that we have less than 4 effective medication in the regimen. Okay, what happens after 9 or 12 months? You don't have enough medication after 12 months. Well, we don't have that much of experience, so we can't really tell as of now, because first of all, period is very short and it's too difficult to tell. Well, originally, when we started treatment, you know that doctors are thinking. Doctors think within some framework, okay, within some treatment framework, and they are afraid of using, a longer period of time use with children and others. So we had to consider this opinion of doctors. Some doctors would use for 6 months and then cancel bedaquiline or dolomonide and have less number of medication after 6 months. And patient would have bacteria development after that period. So in that case, we started thinking about continuation. So we needed to get oriented whether patient was getting treatment or not, one side, two side, when conversion occurred, first month, 6 month. I mean, there are many factors that can contribute. So we look individually at patients. In some cases, there are some patients have to stay on 3 drugs, but if those patients that had infiltration process without the relapse and with the positive dynamics, they don't have to pass through surgery correction, have no side effects of comorbidities, we can conduct a follow-up or supportive stage on the 3 indications. But anyway, this is our practical experience. Whether it's correct or not, I don't know.
So I think the question is really good. Actually, it's if you use these drugs because you don't have enough drugs, so why would you stop them? Actually, so I think that's the basics. I mean, I just can tell from my experience of what we do in France. Since the beginning, it just. It was not a study, but we just spontaneously started prolonging the treatment duration with the new drugs, just because we didn't want to weaken the regimen. And then when we looked retrospectively at the data, we found out that almost all the patients that got prolongation actually got all the drugs until the end of the treatment. So I think it's really individualized. On this I agree completely, but at the same time, we should think before weakening again the regimen exactly because it works. So why would we will change it?
Yeah, and just to complement the 2 speakers previously, the experience from NTB, so it's 17 countries, at least 1/3 of patients so far are getting more than 24 weeks. And this is increasing in proportion because initially there was some hesitancy, but now as doctors are very used to using these drugs, it is against everything they have learned to stop an effective drug when you don't have enough effective drugs. And I think what we learned from compassionate use, when we were obliged to stop at 24 weeks and we saw 20% reversion after conversion, it really illustrates now. You see in NTB, only 3 patients, less than 3% of patients reverted. When you keep enough effective drugs in the regimen, you get better results. And it's just, the basic thing we always learned as doctors treating MDR. So, and I just want to clarify, it is not off-label, and we should stop calling it off-label. I'm not sure why WHO actually called that guideline off-label. The only off-label use of bedaquiline and dolomonide is actually in children, and even WHO recommends off-label use in children for dolomonide because there's evidence for it. The only reason they can't give a recommendation on more than 24 weeks or on combination is because there's no evidence. So all I can say is be the good doctors that you are, treat the patients correctly, and give WHO the evidence so they can actually make a recommendation would be useful.
Okay, any more questions, please? Good day. I am a coordinator of the TB penitentiary system, the Kyrgyz Republic. Okay, first, using this opportunity, I would like to greet all women and congratulate you with the upcoming International Women's Day, 8th of March. We won't have other chance to do that. I have a question to Bern. Thank you for your very interesting and great presentation. And one of your slides, if I'm not mistaken, criteria for inclusion was or exclusion, not to include TB patients in prison into your study. Why was that? What was the reason for that? I mean, any documents?
I'm not sure whether it was for you or for me, but okay. Okay, so I would say I think the main challenges with regards to including patients in prison is really the point whether how do you make it clear, or how can you have enough evidence that these particular patients actually willingly joined the clinical trial? And I think it's not that it's not possible to do. You can definitely include patients in the prison, but it is in a situation where it is very difficult to establish that these patients who are unwillingly staying in a particular place actually willingly decided to join a trial. And that is a challenge. But I think if there is always an interest, and it is possible to do that. There are just significant ethical hurdles to get over. Yeah.
Спасибо всем.
Thank you
Думаю,
all.
что сессия получилась очень
I think the session. Hello. Yes, guys, it's 1:20. We only have 40 minutes left for the lunch. That's it. Thank you.